With me, I have Dr. Tara Scott, and she is known as the Hormone Guru. And Dr. Tara helps people find the cause of their symptoms and get them on a path to optimal health. And with over 25 years of experience and three board certifications in OBGYN, functional medicine, as well as integrative medicine. So Dr. Scott has helped thousands of patients struggling with hormone issues, and this includes endometriosis, breast cancer, weight gain, and other conditions. So Dr. Scott has been speaking, including a TEDx talk, and as well as educating for over 10 years, and has taught doctors her approach in 5 continents. And for her expertise, she has been featured on the List TV, Women's Health, Shape, The List, Newsweek, Parents, Authority Magazine, and on numerous podcasts. And thank you so much for joining us, Dr. Tara.
Well, thanks for having me.
So when did you do that TEDx talk?
It was last October of 21. And so it's still in final editing. It's not up on the TEDx page yet.
Okay, wonderful. All right. So before we start diving into the questions about hormones, I'd like you to just briefly discuss your background. So how did you become known for helping people with different types of hormone imbalances?
Well, I am a traditionally trained MD and OBGYN. So I entered, after residency and training, was in a very busy practice, delivering a lot of babies. And then I had my own struggle with infertility and had my own hormone imbalances. And so wasn't ever able to get pregnant without fertility drugs. And thankfully, due to that, did get pregnant. But after that, when you have a hormone imbalance, you either are trying to get pregnant or you're trying to prevent it. So there's nothing in between to help balance it. So I became interested in women's hormones, and I first became a certified menopause practitioner with the North American Menopause Society, and then really did a lot of studying on bioidentical hormones and perimenopause and menopause. And I think the more you learn, you find out the less you know. So that's when I went ahead and did a fellowship in functional medicine through A4M, and then also was able to sit for my boards from the integrative medicine boards, the American Board of Integrative Medicine as well. And so I really have focused on women's health for the most part and have expanded it kind of just to, integrative medicine. We're talking about all things that affect women and their hormones, including the gut, including thyroid, adrenal, metabolic issues are all kind of connected.
So when it comes to hormones, a lot of people have low sex hormones, low estrogen, low progesterone, low testosterone, low adrenal hormones. But when it comes to the sex hormones, why do so many people have these low sex hormones?
I think one of the biggest reasons, at least today, that people are having low hormones is the effect of stress. Both men, your testosterone can decrease as the effect of chronic stress. And we've got DHEA, which is made in the adrenal gland, and that's a source for men and women of hormones. And we've all had so much stress. I mean, if you were stressed before the pandemic, then you kind of capped it out. Our lives are just different now and changed. We also have environmental stressors, all the endocrine disruptors in our environment that is affecting. So, which came first, the chicken or the egg? The environment, which changed and made everybody have issues with the obesity epidemic, which certainly feeds the issue with your hormone issues, suppresses ovulation, and the way your body gets rid of estrogen as well. So it's kind of like a vicious circle.
Would you say that low progesterone is probably the most common hormone imbalance as far as like lower sex hormone?
Yeah, so for women, that's very common. You're born with so many eggs, and the good eggs are obviously released first. And we all know that when you're trying to get pregnant, over 35 is called advanced maternal age because you have an increased risk of chromosomal problems because the eggs aren't as good quality. Well, even though we're not trying to get pregnant, potentially, it still would transfer. If those eggs aren't as good quality for pregnancy, they're not as good quality for hormone production. So it's very normal over the age of 35 and certainly 40 for your progesterone to decrease. But there exists this phenomenon that stress can affect ovulation, again, can deplete your hormones, your hormone precursors, can prevent ovulation, which would prevent you from producing estrogen and progesterone. So that all can be tied in.
Yeah. And like you said, stress is huge, really, with all the hormones. So when it comes to not only progesterone, but estrogen, testosterone, adrenal hormones, DHEA, and cortisol. How about elevated sex hormones. So estrogen dominance, elevated testosterone levels. What are some of the causes of those?
So for a female, estrogen dominance happens when either one, you don't have a lot of progesterone as you age, two, you just make a lot of estrogen. And that's common in the perimenopause because these old eggs, they can't hear. The brain is sending out a signal called FSH to stimulate the egg to grow. When the egg is old and it can't hear, it requires more of that pituitary hormone, the FSH and the LH. So what you have then is an increase in estrogen as you get older, and also an increase in testosterone at that particular time. But you don't have an increase in progesterone that follows because those eggs ovulate and you still have poor quality follicles. So you have low progesterone. You can also see high testosterone in younger women who are not ovulating for the same reason, because there's FSH and LH that are increased, and it's that LH that stimulates the production of testosterone. So you get high testosterone, as in PCOS, or someone who's not ovulating. And then it's a vicious cycle because high testosterone prevents ovulation.
And then also with high testosterone, it could also be part of like one of the potential causes, or at least factors, is insulin resistance, like PCOS. Is that correct?
It's definitely related. I mean, there's no agreement as to what the inciting hormone imbalance is with PCOS. Some say it starts in the pituitary. You have abnormal pulsations of the gonadotropins. The second theory is that it starts with androgens. And the theory to support that is because you'll have high androgens in two different cell lines. You'll have high DHEAS and high testosterone, which comes mainly from the ovaries, not the adrenal. And so but a lot of girls who are young will have higher DHEAS. And the third theory is that it comes because insulin is high. And you have high insulin, you get insulin resistance, which suppresses ovulation and causes the whole vicious cycle.
Okay, you mentioned DHEAS. I'm glad you said that, because I've seen some of my adult patients with elevated levels of DHEAS. And so I guess two questions. One, can you explain for those who are not familiar with the difference between total DHEA and DHEAS? And then what are some of the potentially other causes when you see DHEAS elevated on a test?
So DHEAS is the sulfated form of DHEA, and it's the most populous hormone in our human body, men and women. There's just the most quantity. So DHEA goes through the liver. It's made in the adrenal gland. And it gets sulfated in the liver. DHEA is the unconjugated form that's made, and it's a much lower quantity. So we always monitor DHEAS. So I always explain to my patients, think of your ovaries as your monthly paycheck. You're getting a little bit of estrogen every month and some progesterone. But your 401k or your savings account is your DHEA, because that's your adrenal gland. And when you retire or you stop getting paid by your ovaries, you're going to live off of that bank. So DHEA is highest in your teens and 20s, and then it kind of decreases as you age. When it would increase, it would be when everything is upregulated in times of stress. So think of, you're running from a bear. So the brain doesn't know if you're running from a bear, you have a deadline in work, or you have just lost your job because you have a pandemic or you have COVID. The physiological response to stress is the same. Get cortisol up to get blood sugar high to fuel your muscle so you can run from the bear. So the resultant increase in cortisol, it's like fire. So DHEA will it'll be a compensation to try to be kind of like a teeter-totter of a catabolic anabolic in your adrenal gland and your homeostasis. So DHEA will go up as a response. But here's the difference between cortisol and DHEA. There is a feedback loop with cortisol back to the brain, but there is not with DHEA. So what eventually happens is DHEA goes up at first with stress, and if stress is prolonged over time, it's going to decrease, but there's no signal that goes back to the brain saying, hey, DHEA is low, let's make some more. There is for cortisol, there is for testosterone, and there is for estrogen, but not for DHEA. So a lot of people will have DHEA that is decreasing, and nobody really checks it in the traditional world. I know in the functional world we check it, but not really in the traditional world.
Yeah, and I should mention that most of the time when testing for DHEA or DHEAS, it's usually on the lower side, but there's been situations where I see it elevated. So I just wanted to get your opinion, and thank you for for sharing that. So I work with a lot of hyperthyroid patients, and I have a history of Graves' disease, as I mentioned as we were chatting before this interview. So with hyperthyroidism, a lot of people lose weight, but some people do gain weight. And then, I also work with Hashimoto's patients who also have more of a tendency to gain weight. And of course, there could be many different factors when it comes to weight gain. But when it comes to sex hormones or even adrenal hormones, can you talk about the relationship between some of these hormones and weight gain?
Yes, actually, that is a main thing that I think is overlooked. And a lot of women go to their providers and they say, I've put on weight, and they say, I'm exercising, I'm eating less. And their providers sometimes dismiss them because they think all that has to do with weight is calories in and calories out. Well, I can tell you that for a woman, if you're not hormonally sound, that will not work. We do know from some studies out of the University of Colorado that around menopause, your basal metabolic rate will drop. And exercise does not counteract that. And so a lot of women around the time of menopause will start to see weight gain in that visceral area and in their abdominal area. And in those studies, like I said, they tried to increase exercise, and it did not counteract this drop in basal metabolic rate and weight gain in the abdomen. But then they did another arm where they gave estradiol, bioidentical estrogen, and that did counteract the AE. So you have to have estrogen. Actually, all your hormones are kind of like Goldilocks, right? Too little is no good. Too much is no good. It's all on a bell curve that the symptoms on either end can be similar. We also know that estrogen is a growth hormone. So it makes everything grow, specifically tissues like breast, hips, that kind of thing for women. So having too much estrogen without that balancing progesterone can be another factor in weight. You mentioned low androgens, low testosterone. I mean, think about a man and his body fat when he has enough testosterone, and a man in his body fat and where he distributes his fat when he has low testosterone. He usually gets man boobs and a big pregnant belly, right? That's usually because either he's got low testosterone and his balance between testosterone and estrone, which is just one enzyme dividing them called aromatase. Usually that's how they distribute fat. So men normally with the normal amount of testosterone are going to naturally have a lower body fat, where women don't, because we have to grow a baby, we have to store fat for that. So estrogen's job is to get you ready for a pregnancy. So without that balancing progesterone, you can gain weight. With low DHEA and low androgens, you can gain weight. With high cortisol, your body's constantly trying to get the blood sugar up, and then cortisol goes up, blood sugar goes up, then insulin goes up, and then they start fighting each other. Then your insulin stops working and you become insulin resistant. So that can be another hormone that can be off. And certainly you can have what we call a functional hypothyroidism. So we all know that, as a thyroid expert, the TSH is made in the pituitary gland, the T4 is made in your thyroid, and really it's the T3 that's the active form. So it's kind of like clocking your hours. That's your TSH. Your paycheck would be your T4. But then you have to cash it. You can't walk into Walgreens with a paycheck. You need cash. So T3 is what you need. These hormones are tightly bound to binding proteins, which estrogen will manipulate. So if you have too much estrogen, it's going to increase the binding protein, and you're going to have less free hormones that are available at the receptor. In addition, there's that enzyme that has to be cashing your check, that 5' deiodinase, right? If you don't have enough iron, if you don't have enough vitamin D, if you have too high or too low cortisol, which most of our population does now, you're not going to convert that T4 to T3. Instead, you're going to convert it to reverse T3. So that's like taking your paycheck and putting it all in your 401k. You have the money, but you can't get to it. It's reverse T3. So I think that's what is missed a lot with women patients and potentially men too, but the effect of estrogen on cortisol, on insulin, on thyroid is really predominant.
Yeah, so it's all really interrelated, interconnected. And as far as knowing whether or not it's a hormone problem, I imagine really the only way is through testing.
Yes, I mean, you can take a history, and if someone comes in with weight gain in a specific area and they have really heavy periods, I mean, more than likely it's estrogen if they're 42. But you're right. I mean, I think it's it's always hard to guess and know what the hormones are. So it's always better to test. And I don't know why there's such resistance in the traditional community. My traditional colleagues that are saying you can't test hormones, they fluctuate every day. There's no validity to testing hormones. Yet we test male hormones all the time with pre-testosterone replacement, post-testosterone replacement. We have no problems testing hormones when you're going through fertility treatments. I went every day for estrogen levels when I was having my IVF and everything, and we tested progesterone levels, so it was valid then. So why is it not valid when you're not trying to get pregnant? It's really confusing. So we can test hormones, even if you've been told we can't.
Yeah. And then, as you mentioned, things like T3, the active form of thyroid hormone, many times they don't even test that. So when they do test, usually it's in the blood, which for thyroid, that's the way I test, doing a blood test for thyroid. But then with other hormones, again, not to say blood doesn't have value when testing for the sex hormones. Dried urine testing, the Dutch test is one way. Even saliva testing, which I don't use, used to use actually in the past. I use that sometimes for adrenals, but I actually use that in the past for sometimes the sex hormones too. But I guess the point is sometimes they don't look at the complete picture, or I should say many times when you go to a regular medical doctor, if they are willing to do any type of testing, maybe they might just do for thyroid, just a TSH alone. Sometimes they'll do a TSH and free T4. And it depends. Obviously, there's some medical doctors that do the entire thyroid panel. And same thing with sex hormones. Many times they are resistant to do any testing at all. And then when they do, they'll try to get away with the bare basics.
Yeah, I know that in places like Canada or the UK where they have the NHS, they are limited. They're not allowed to order the reverse T3. They're not allowed to order T3 generally. So we don't have those limitations that I know of in the United States. I mean, I've been an employed physician with the hospital system, and they never told me not to order certain things. They may not be covered by insurance. And thyroid isn't as controversial as far as how to test. It's just what to test. We all agree that blood is the best place. Thyroid hormones are large peptide hormones. They're not lipophilic, steroidogenic hormones. They're peptides. So it's a little bit different in the blood. They are bound, of course, we have the assays to do free assays. We don't for sex hormones. I mean, we have, I guess, free testosterone, and I sometimes have seen a free estradiol, but it's not that common. Like with progesterone, you don't know if you're getting a free assay.
Yeah, I've actually seen I think it was LabCorp, where they do offer the free, I think it is free estradiol and maybe even free progesterone. I never see any doctors order the free, other than, like you said, the free testosterone. And then, of course, with the thyroid hormones of, free T3, free T4.
Well, we do have now an ultra-sensitive estradiol that seems to be a lot more accurate. And if you order the LCMS, it's supposed to be more accurate also assay. So I know if you order progesterone LCMS and estradiol ultra-sensitive at either Quest or LabCorp. So those are getting a little bit better. And there's some data coming out of the North American Menopause Society about those lab assays as well.
I don't know if you can answer this, but when it comes again to blood testing and sex hormones, I've noticed in some patients and I don't know where I started testing for total estrogens, but sometimes estradiol will look fine and then total estrogens are elevated. Now, obviously there's multiple estrogens. There's estradiol, estrone, estriol. So would that be your explanation where, if total estrogens are elevated, but estradiol is looking fine, that maybe it's more related to like estrone, for example?
So first of all, estriol is very hard to measure in the blood because it's a metabolic byproduct of estradiol and estrone. So it's not made and circulated in the blood. It's only made during estrogen metabolism. So then we're talking about estrone and estradiol. And so 95% of your estradiol comes from the developing follicle and from the ovary. Estrone is made a lot of different places, but mostly with aromatization from DHEA or testosterone. There is a bidirectional enzyme, 17-beta-HSD, that you can make estradiol into estrone and vice versa. So when we're talking about blood, you got to think about what are you measuring? Where is it coming from? If you're measuring blood levels on somebody who's having a menstrual cycle, their ovary is producing those hormones and putting it out into the blood. But if you're measuring someone who's postmenopausal, it's not coming from the ovary. It's happening in the periphery, right? In the muscle and fat. DHEA in the periphery is converting to either estrone, and it may convert to estradiol. So you wouldn't expect to see a high estradiol in somebody either postmenopausal, not on hormone therapy, or someone with no ovaries. That would be like if my 20-year-old daughter said, Mom, I'm going to the library tonight to study, and she left the house in sweats. And I thought, I'm so lucky. She's such a great kid. She gets to her friend's house. She pulls off her sweats and she's got a tank top and a miniskirt. She pulls out her fake ID and goes clubbing. I'm never going to see that conversion because it happens outside of my house. So the estrone, estradiol to estrone, testosterone to estrone, DHEA from androstenedione to estrone, that all happens outside of the blood. So I don't know how accurate that estrone is in the blood. Yes, I will see it high. If it's so high that it's recirculating, and that bidirectional enzyme. So I've seen those assays of the total estrogens, and I don't prefer them. I would prefer to do the estrone LCMS and the estradiol ultrasensitive. And again, if you're somebody who's menopausal, I have seen estrone go up almost to compensate because your estradiol is low because your ovary's not working. And then sometimes if we give them an estradiol patch, that may drive the estradiol up and you'll see the estrone come down because those hormones act differently at the receptors. And, the concentration is important.
And then dried urine testing, such as the Dutch test. The Dutch test is one example. Of course, there are a few other labs that perform that. But one of the big advantages of Dutch test is looking at the estrogen metabolites. Would that be the main advantage then? Like when it comes to, if you were just wanting to look at just estradiol, estrone, estriol, progesterone, would you say there is an advantage looking at the levels in the urine compared to the blood?
So I think that the Dutch test is a great test and we do a lot of it. And so I kind of analogize it to, like, if you came to me and you said, I'm bankrupt, I can't pay my bills, I would wonder, are you not making enough money or are you spending all your money? What is the problem, right? Maybe you make a lot of money, but you spend it. So when people have a lot of estrogen, it's good to know, are they making a lot or are they just not getting rid of it? It's kind of like charging on a credit card and not paying off that balance. You could cut up that credit card and never use it, and you'd still be paying a finance fee, right? If it went on long enough. I see that in women. So the Dutch test or the dried urine is all your hormones that are being excreted. That's like me looking at your receipts and seeing how you spend your money. My accountant doesn't care what my bank balance is. He wants to know, what did I spend on rent? What did I spend on payroll? What did I spend on supplements? What have you, salary? So he wants to see how I break it down. And that's what we see in the urine. I think it's also a great way to look at your cortisol because you get your cortisol and your cortisone metabolites. What's going on with that 11 beta HSD? So are you favoring conversion to cortisone? You can see how you metabolize your androgens. Do you have a 5 alpha or 5 beta preference? So that's really helpful. But I think one of the reasons we really missed the boat on hormone therapy with a lot of people is this estrogen metabolism problem, because people have, one, they can have genetic SNPs that affect estrogen detox, or two, their environment or lifestyle change choices affect those enzymes as well. So giving one person estrogen, another person the same dose, if one has good estrogen detox or they pay their bill every month, they might be fine, where the other person might get the exact same dose, but accumulate estrogen.
So stick with the topic of estrogen metabolism. If someone, let's say on the Dutch test, they're showing higher levels of the 4-hydroxy metabolite, the 4-hydroxyestrone metabolite, which is the, I hate calling it the bad estrogen because they're all important. You just don't want it to be too high. But let's say that's above the range. It's showing low methylation. Would you mentioned the SNPs, the genetic variations. Would you dig deeper and do recommend genetic testing for COMT, MTHFR, for example?
Yeah, we do in many of our patients, especially my patients with breast cancer. And so there is data that says a high 4-hydroxy estrone has been isolated in breast cancer patients. If it's not detoxified, it can, intercalate and agonize DNA and cause rapid, division and everything. And so there haven't been a lot of studies that looked at it because it's just not a focus. But, I found quite a few that do reinforce that.
So you mentioned breast cancer. Would that also, if someone has like elevated 4-hydroxy metabolites, could that also be a factor with other conditions such as endometriosis, uterine fibroids as well?
Yeah, so endometriosis is a tricky disease. There is an abnormal hormone response, but we're finding out so much more that it also involves inflammation, involves a altered immune response as well. So yes, it is driven a lot by estrogen. Fibroids are a little different. It's different tissue. Endometriosis is a tissue of the uterine lining or the endometrium that responds to estrogen and quiets down with progesterone, whereas fibroids are a different cell line. They're part of the muscle. So there's data that shows that both estrogen and progesterone play a role. Now, I haven't been able to pin down the authors and say, is it progesterone or is it progestin that also stimulates the growth? But I just did a talk at the World Congress on Fibroids, so I looked into this data, and I was surprised to hear that progesterone may play a role in fibroids. So it's because it's a different cell line, it acts a little bit different than endometriosis. Endometriosis is also altered immune response and inflammatory. Fibroids also, but not quite as much as endometriosis.
So you're saying that as far as the estrogen imbalances, that would be a greater factor, the hormones when compared to fibroids? Because I know you said endometriosis, there are other factors too, like immune system, and you mentioned a few others. I just want to make
Yeah,
sure I understand.
I do see that for sure. And at least with myself, I have estrogen metabolism issues. I had endometriosis for many years. And so that seemed to be the case for me. And once I kind of fixed my methylation, you got to fix the gut and everything and all that, then I don't have issues with it now. For fibroids, it's not as a common thing. So I can't say that I've done quite so many Dutch tests on people with fibroids. So I had one patient that had rather large fibroids, and she did seem to have lower progesterone, but it wasn't terrible, and her estrogen detox was flawed. But for what the studies are showing is that it's almost like estrogen primes the growth and progesterone also contributes to the growth. So I'm not sure that's clearly understood as far as the mechanism and the connection to hormone issues with fibroids right now.
I've seen research studies when it comes to thyroid nodules showing that potentially problems with estrogen metabolism, as well as other factors too, like insulin resistance. I don't know if you've seen any of the research or in your patients, because I know you also work with thyroid patients. So have you seen any connection there?
I haven't seen any data on thyroid nodules. I mean, are you talking about hot nodules or cold nodules or, but
Yeah, it didn't specify in this. Actually, one of them showed both nodules. It just said thyroid nodules as well as uterine fibroids. It actually mentioned estrogen in those, but none of the studies I saw actually mentioned specifically like what type of nodule.
yeah, I mean, there's definitely that relationship we discussed with estrogen and thyroid. So I would not be surprised if there was a connection there.
And you mentioned breast cancer as well. So whenever one of my patients has a history, like a family history of breast cancer, or obviously if they personally had breast cancer, then I would recommend doing a Dutch test. And I'm guessing you also recommend probably in all these conditions, endometriosis, again,
Exactly.
uterine fibroids.
Those are all conditions that I think the Dutch test is extremely beneficial for.
How about cycling women? Because that's another advantage of the dried urine testing is that they can look at their cycle. They can look at the hormones throughout their cycle and not just a single snapshot, which is what you're getting through blood testing. Would you recommend just certain cases? I guess the question is, when it comes to cycling women, would you recommend for all cycling women to get that cycle? I forgot what it's called. Is it the cycle
It's
map?
called a cycle map. That's available both in salivary and urine.
Mhm.
So there's a company that does it in salivary. I think it's Genova.
Diagnostics also does that. They're one of
Yeah,
the
I've seen. I'm
largest.
not like I don't love their assays, but Genova does a cycle map,
Okay.
saliva, and then both ZRT and Dutch do for the urine. So, gosh, if everything was free in the same price, I'd have everyone do that, but it's not. The cost is really prohibitive for our
Yeah.
patients. I mean, I'm in middle America. I'm not, so I think it's over $400 to do that test. And I guess that makes sense. There's a lot of collections, So Mark Newman from the Dutch was telling me like how hard it is to process those tests because there are a lot of things. So if somebody wanted to do it, I would love that information. And in the patients that have had the resources to be able to do it, it's been extremely valuable information for us in their case.
How about like a fertility case? I
Yeah.
assume that would be a good
Yep.
reason to do that, because obviously if they're doing IVF, they're spending who knows how much money on that. So when you compare the cost,
Right.
but I agree, the average person, I don't recommend the cycle mapping test either. Just
Yeah.
certain situations. All right. Well, I think we covered as far as testing. Obviously, there's a lot more we could talk about with testing, but how about as far as balancing out the hormones, different treatment options? I think earlier you mentioned bioidentical hormones. So, like, when's the time for bioidentical hormones? When's the time for using herbs and other more natural methods?
So my kind of protocol would be, everybody really should start with diet, exercise, lifestyle, stress management, right? Everybody should do that. You can go pretty far from cleaning up your diet, getting off inflammatory foods, decreasing your alcohol and your sugar, taking the plastics out of your environment. For a patient that's younger and their teens and 20s, I'm more likely to try something like Vitex, which is an herbal supplement. Look at their estrogen detoxification and see if we can help and foster, like you mentioned, the COMT enzyme. Sometimes it's a problem with phase one detoxification, so we'll work with that. When you're getting in an older woman who has a lot of estrogen, my concern is the health of the breast and the uterus and the increased risk of breast cancer with all that estrogen. And we know that estrogen upregulates its own receptor and progesterone will downregulate its receptor. So I more feel compelled to use progesterone in somebody like that because I know that progesterone will cause apoptosis or cell death, which is what we want. We don't want the unregulated cell growth. And then when you're talking about the indications for menopausal hormone therapy, it's individualized. I mean, we know that it does. The FDA says the indications are vasomotor symptoms, prevention of bone loss and osteoporosis, and then also vulvovaginal, which now they call genitourinary symptoms of menopause, GSM. Those are the FDA indications. Although there have been studies that show a 19% reduction in diabetes, we can't say that it will reduce your diabetes. We can't say that it will prevent heart disease, although there's a lot of data saying that it has a favorable effect on your cholesterol and does reduce the risk of heart disease. We can't say that because they didn't get the indication for that. But more importantly, there were some studies out of the Women's Alzheimer's Translational Research that they looked at over 400,000 women taking hormone therapy. They saw a 60% reduction in neurocognitive disorders, including Parkinson's and Alzheimer's. So that's a pretty steep reduction. So there's a lot with estrogen and brain health that we're still just trying to find out, estrogen in the older age. And then there's all the vanity symptoms. Like I talked about the weight and those studies on the University of Colorado. Yes, bones, yes, heart, hair, skin, mood. There's a lot of studies about depression in midlife because of low estrogen, anxiety, those kind of things. So I think, it's an individual choice. I don't think every single person needs to take hormones, but I think every single person needs to be told of the risks and benefits and alternatives and given that option.
Great. So it sounds like obviously everyone you're going to recommend dietary changes, lifestyle changes. And then, as you mentioned, when someone is younger, less likely that you recommend hormones. I'm sure there's a time and place, sometimes even in younger people, but more so it's the bioidentical hormones. When you do recommend it, it's in women in postmenopause and certain situations, but like you said, it's not everyone. It's not like everyone in postmenopause will get bioidentical hormones, correct?
That's not my practice pattern. I know some
Mhm.
places they're like, oh, take your hormones and your skin will be, the Suzanne Summers kind of approach of still have periods at 80. And, it's good to have your periods and it's good to have all this estrogen. So I'm not really kind of in that camp.
And I agree. I can't prescribe bioidentical hormones, but if I could, I don't think I would recommend it to. I'm pretty sure I wouldn't recommend to everybody. I would try to do things to optimize their adrenal health and gut health. And again, there's a time and place, just like there's a time and place for thyroid hormone replacement. So you mentioned Vitex. So like if a younger woman, a woman of cycling age, if she had low progesterone, Would you automatically recommend that? Or again, just certain situations, like would you work on adrenal health first? And then if the,
Yeah, we're always working on adrenal health and diet and stress and everything. Some of them might start with something called seed cycling, which is a regimen where you do certain types of seed in the first half of the cycle to kind of boost your estrogen, and a certain half of seeds in the second half of the cycle to boost your progesterone. So that's another alternative. The Vitex is not progesterone, does not cause apoptosis, doesn't have the benefits of downregulating the estrogen receptor, but somehow works with the HPG axis to try to foster your own body to have a better quality ovulation. I don't really know what the exact mechanism is, somehow through the HPG axis, but it's not progesterone. So if I'm worried about at the cellular level, upregulation or downregulation of estrogen receptors, or hyperplasia or apoptosis, then I'm more likely to go with progesterone.
sounds good. And what are your thoughts on maca root?
So maca is I can't say that I'm an expert in that. I've looked into the data on it. I think what I've seen it mostly is helpful for is libido, and it's an adaptogen. I know some hormone preparations that have like a lot of stuff in it might have that in there, plus the Vitex and plus some bees and some things like that. So I don't have a lot of experience with that myself.
Okay. Yeah, I was just curious. Just figured I'd pick your brain on that. And I mean, there's so much more we could talk about, but is there anything really urgent, I guess you could say, that I didn't bring up that you thought I should have asked you?
Well, I guess the biggest thing, why I always kind of jump at the chance to educate people is that, I want to validate women out there. The people that are struggling, the people that have been dismissed, the people who have had these symptoms and they don't really know who to go to. They're thinking their PCP should know. They're not trained. They're thinking their OBGYN should know. And I'm telling you, as a traditionally trained OBGYN, we do not get this kind of training. So they don't really know who to go to. And they're told we can't check hormones. And I think absolutely they should be checked. People should have the option. Doesn't mean everybody needs to take something. There, as you see, we discussed many options, from food, from lifestyle, from herbs to hormones. So I just want to encourage anyone who's really struggling, and if they have their gut feeling is telling them something's wrong with their hormones, they may have gone so far to had gotten a doctor to order hormones, and they say they're normal because they don't know how to interpret them. So it's frustrating. And so really that's just my message, and my megaphone is why I spend time on social media and try to educate, just to really advocate for people and educate them.
Thank you. Thank you so much. And you're right. Like if someone does, let's say, a Dutch test on their own, and if they were to bring it to their medical doctor, most medical doctors probably really wouldn't know what to do with it. Some might be interested, but most of them probably be like, I don't do that type of testing. And maybe they'll recommend something in the blood, or maybe they'll just say, go to someone else to interpret it, which probably is a good idea, to go to a functional medicine practitioner, someone like yourself.
Well, hopefully that would be what they would do instead of really slamming it and saying, I've had providers saying, anyone that talks about the Dutch test, unfollow them immediately. Because those providers get money from the Dutch test. Do you get any money from the Dutch test? Because I don't get any money from the Dutch test. So it's just kind of crazy.
Yeah, I deal a lot with, especially with the hyperthyroid patients, seeing endocrinologists, and they don't want to hear anything just about diet or lifestyle changes. It's all about either taking the medication or getting radioactive iodine thyroid surgery. And, similar with Hashimoto's, it's, take your thyroid hormone replacements, nothing else is going to help. So a little bit similar here. But where can people find out more about you, Dr. Tara?
So they can follow me on TikTok. I'm Hormone Guru. And on Instagram, it's Revitalize Med. I've got an online course at hormone-guru.com where we have a lot of free programs. We have some, courses for sale as well there that they can enroll in at their own pace. And usually we're always doing kind of workshops and things like that as well. And those are the main things. My YouTube is Tara Scott MD. So I'm trying to also upload things there as well. It's a little bit easier to search there than in the TikTok format. So I'm trying to get caught up on that as well.
All right. And I'll make sure to include these links in the show notes, including to the online course. And thank you so much. Thank you so much for doing this interview. I learned a lot, and I'm sure the listeners did as well. And I appreciate you taking your time to share your knowledge with others.
Yeah, and thanks for the time that you're putting into this, because it's your time as well to try to educate people.